Well, thank you, Fred, and thank you for having this series. I know it's important to capture the old people right before they pass over into senility. So we're here today to talk, I hope, about the 40-year war on cancer. I'm going to move here just a little bit so I can see what I'm doing. From the beginning, I must say this is my perspective over 40 years of experience. But there is a Pulitzer Prize-winning book if you're really interested in what's going on in the history of oncology in the last, well, actually two millennia, but also more particularly what's gone on in this country in terms of research since World War II and where we are and a variety of things. I don't use this book except for maybe one quote, but I did substantiate certain chronologies that I might have otherwise fouled up. So we are going to talk about the 40-year war on cancer. This coincidentally started, was declared when I was standing about 5 miles from Nixon signing this in my fellowship. And I don't remember particularly, I must have been really pretty dull to the current events in oncology because my preoccupation at the time centered more around the Vietnam War, the fact that Nixon had already started with the Kissinger's input bombing Cambodia. So there were a lot of things on our plate. I was busy too trying to learn how to take care of the different subtypes of lung cancer, which we clearly had identified even that early on. Well, there I was 41 years ago as a fellow here with Bill Larson taking a very sharp stick and going over to Howard Wilcox and putting it up his nose. No, he didn't actually do that. But then you can see that times have really changed. And I feel changed, much older obviously, and this was last month when I was getting prepared for this talk. What we'll try to cover in the next 35 minutes or so are listed here. Background of the Cancer Act, I kind of look at what's going on in the space program in the 60s and 70s, because the notion that everything could be done if we just concentrated enough effort and money into it grew out of that space exploration. We'll talk about the Cancer Act briefly itself, look at some of the accomplishments that have occurred in my 40 years, and I do think there's a lot to talk about. We've had some downtimes as well, so there's been some false starts and false hopes, and we'll talk a little bit about those. Of course, the present, right now, targeted therapies more specifically designed for individual tumors, again emphasizes just how common and how unique cancers are from patient to patient. We all know people as human beings are unique, but now oncologically we know how unusually unique they are from a molecular standpoint. We have some social and economic costs for which I'm not qualified to go into in depth, but I will share some superficial notions with you. Well, actually the war starts right at the end of World War II. You have a tremendous interest by particularly Sidney Farber in Boston, a pathologist, by the way, who said, you know, I'm tired of autopsying all these children with acute lymphocytic leukemia. I think we can do better. And in fact, he starts toward the combination chemotherapies that have become the backbone in the treatment and the cure of this disease. Well, more recently, I was about 1 month into my undergraduate program, and everybody said you have to be an engineer because the Soviet Union and Russia have just launched a satellite, and we are way behind in this regard. And interestingly enough, this was out of the paper yesterday. I think it's the Kansas City paper. John Glenn, who is now 90 years of age and went back up into space in the shuttle in 1977, of course, was our first American to circle the Earth, the Mercury 7 program. And then we had the really defining moment with Aldrin standing on the moon in Apollo 11. And then we started putting all kinds of junk on the moon in Apollo 17. And of course, out of this notion, if we can land a man on the moon, we can cure, quote, cancer. That's just no way. If we just devote our energies and our time to this, we can, no problem. Well, there's a bit of a caveat about space and contamination of the space with the debris. There are now satellites circling. This is an artistic rendition. There are 20,000 pieces of debris circling the Earth at 17,000 miles per hour. And when some of these are the size of a bus run into one another, they then shatter into yet even more particulate matter that circles and orbits the Earth. I'm going to come back to this because we're in an era where targeted therapies for cancer patients may actually begin to look a little bit like this. We have some specific things. You were mentioning World War I. Dr. Holmes and I, Fred, we were talking about the great resources that are here in the Kansas City area for studying medicine in World War I. A couple of pathologists in Pennsylvania but got a hold of and were able to do autopsies on a number of soldiers killed in World War I by that terrible gas, mustard. That in and of itself called attention to what was going on with the cytotoxic agents. The lymphatic tissues were just atrophied in all of these people, plus the skin damage, of course, that occurred. So they began to put two and two together. If we have something that really knocks out lymphocytes, maybe we have something that would injure cancer patients, hopefully not the patients, but the cancers in the cancer patients. Farber, as I mentioned earlier, really gets things rolling with early cures in the treatment of acute lymphocytic leukemia, and it is out of his effort that you see an accumulation of individuals at the NCI at that time, Tom Fry, Freireich, Holland. A lot of people got involved in the notion that if you just gave more and more toxic agents in combination, you could increase the cure rates. And of course, that's where the envelope gets pushed, even today in some instances, and not always with good outcomes. But it worked well, and it was part of the philosophy of the 40s and 50s that if we just got the right drugs and gave enough of it, and in combination, we would have increasing numbers of cures. And I must tell you that that sense of atmosphere was there, very prevalent at the time when I was at the NCI in 1970 and 71. Then Dr. Lee in 1956 said, well, you know, these cancers arising in the placenta, they must be very dependent on folate, because we know the placenta takes up huge amounts of folate. So why don't I give an anti-folate to one of these patients and see what happens? And indeed, metastatic choriocarcinoma was curable. Fred and I actually published a case here where the thoracic surgeon went in to take out a 55-year-old woman's lung lesion and got back the diagnosis of choriocarcinoma, and a very good surgical resident at the time, Mike Bogan, came back and he said, I don't understand where this came from. Well, she'd had a molar pregnancy in her late 40s, early 50s, so this popped up in her chest. Anyway, this is one of the first systemic therapeutic cures after the Farber insights and accomplishments during the 40s. Then Dr. Holmes and Dr. Loveland put some material together, and I use this slide because it helps me give a sense of what happened with Hodgkin's disease. And I'm going to use Hodgkin's a little more than I might otherwise under any circumstance, because this is a disease that had pivotal political implications at the very beginning. And as you can see from Fred's data, we did a little better, patients were doing a little better, and I assume this just reflects not so much treatment intervention, which was very primitive prior to 1970, but the innovations that are ongoing in so many other areas of medicine, whether it's control of symptoms, treatment of infections primarily, that improve the survival over that second half of this. This is very helpful raw data, because nothing in the modern world isn't already contaminated by some kind of treatment. This is what I call, when I was an intern in the mid-60s, we had what I now look back in retrospect call whack-a-mole treatment. With Hodgkin's disease, we'd have a lump show up somewhere in the neck, and we'd throw a little radiation at it, or another place came up, we might throw a little nitrogen mustard at it. And most of us would run back as residents and draw up the nitrogen mustard at the nurse's station and run back out and give it. But one of the things that happens, there it is. One of the things that happens with this disease, in contrast to non-Hodgkin's lymphoma, are these ulcerations that occur, and in places where the whack-a-mole was successful for a couple of months and then recurrence occurred. So that's what it looked like prior to the war on cancer. So the whack-a-mole approach gave way to a couple of very innovative thinking, data-gathering radiation oncologists. One, Vera Peters at Toronto, and Henry Kaplan at Stanford said, well, you know, we keep having recurrences just outside where we radiated. Why don't we get more aggressive with our radiation? So that started the staging laparotomy to find out where all the disease might be in the abdomen. We did a number of these here at KU at the time. And total nodal radiation, the mantle fields, all that became the standard of care. In about 1970, DeVita and Carbone and Serpek published a paper in the December issue of that year's Annals of Internal Medicine, 35 patients with Hodgkin's disease who were given only chemotherapy in the form of mustard, MEM. The O is the oncovin, prednisone, and procarbazine. Now, this combination resulted in remissions in the vast majority that persisted for the 4 or 5 years that they had follow-up on that. So this became the notion that we could take not only acute leukemia and the occasional rare patient with choriocarcinoma that had metastasized and cure these patients with chemotherapy in combination. So this was the fashion for a number of years, MOP chemotherapy. By the 1980s, it became apparent that an Italian group using a different combination of chemotherapy were having fewer in the way of long-term detrimental effects, and that particular combination of treatment disappeared. It's a very noxious long-term, short-term treatment program, but it was resulting in what appeared to be cures. In the 1980s and 90s, you see a tremendous downsizing, if you would, of the treatment approach to Hodgkin's disease. It turns out more is not better, and in fact, we might do better with less. And in fact, now the whole use of even early disease is subjected to chemotherapy alone and no radiation. That recent publication with a large series last month in the New England Journal. So this whole evolution has taken place in the time that I've been associated with cancer and cancer medicine. Well, the war itself was declared by Richard Nixon on December 23rd, 1971. And there are some interesting aspects of this. First of all, the war was declared, and we have the use of chemotherapy, as I've mentioned, the success. And the success with that, I think, led a lot of folks into a little bit of a delusion that, well, all we have to do is just find the right drugs, get aggressive enough, and we'll be okay. We can cure any cancer. And that was the notion that was partially the fault of the clinicians like myself taking care of patients. We were really excited when you can obviously cure somebody with chemotherapy with a malignant disease. Well, the research is really, the clinical, well-designed clinical trials really starts, particularly a surgeon by the name of Bernie Fisher at Pittsburgh. We start looking at a variety of cancers and using adjuvant chemotherapy, and this was not a happy marriage in all instances, but we learned to get along. Of course, we can't have any kind of activity without declaring war. This is a very martial country, so we have had wars on drugs, wars on terror, and of course the war on cancer just simply fit into our verbal vocabulary as a natural. We do have our counterpart, I guess, cage boxing now compared to gladiatorial sports. So we say, well, at the time of the signing, Nixon used language that was really perhaps lamentable. He was caught up in the clinician's share of responsibility for having made him think he could cure and conquest, and that the conquest of cancer was just around the corner. We just devote enough. If we do what we did with the moonshot, no problem, we'll have this disease gone. Well, that was his phraseology. Also, he said, you know, you have any problems, you need any help on this whole thing, you call on me, I'll be ready to. The actual language of the law itself used a less pejorative and less grandiose terminology. The point and the goal of the legislation was to strengthen and to advance our care of cancer patients, and the money was to go to that. In the end, that was a more savvy pronouncement. We do have a problem with cancer and cancers in the plural, and I think, again, clinicians share the responsibility. It's much easier to think of cancer having certain common characteristics, and patients who ultimately go on to die from the disease die of these kinds of side effects, and so they share a kind of a common exit. And as a result, we tend to think of cancer, and we think of palliation of cancer in that context because of the symptoms that they have, including pain. But it also is a bit helpful from a political fundraising point of view. You can, if you just can approach the public and say, we have cancer and we need money, that makes more sense. Everybody kind of thinks that what Aunt Maud had and what Uncle Harry had were the same thing. They were cancers. One was the prostate, one was the breast. They have to be the same thing. They were called cancers. So when I was in my fellowship, I was already struck, and I think anybody who was taking care of patients, even in 1971 and 72, had to be aware of the fact that these were unique happenings in a patient. That one patient with an exact histologic diagnosis as another patient would indeed have a different natural history and different course. And this is what has really happened in the last 10, 15 years, is the identification of those molecular uniqueness of patients, and we'll come to that in just a second. I've got to figure out which one I'm switching here. Anyway, most of you in this audience are well aware of the kinds of things we do look at in the different cancer or cancers, and that certain aspects of their presentation impacts on the prognosis and outlook and our therapeutic decision-making process. And clearly the grade of tumor, and now in the last 10 years, really 15 years, but with an acceleration, looking at molecular and genetic uniqueness of tumors has become. We were capable of a fatuous degeneration every once in a while when this particular spokesman said about cancer, we will eliminate the suffering from death and cancer by 2015. That hasn't worked out, it won't work out, and it was a bit naive, but it did reinforce the notion that you could call this just cancer. So I think we can borrow a little statement from Richard Nixon: the jawbone of an ass is just as dangerous a weapon today as it was in Samson's time. And then a more astute observation: everything should be made as simple as possible, but no simpler. Well, what's happened on the upbeat side of things in 40 years? I've seen a lot of wonderful things happen. They weren't done easily, and they came out of large cooperative group trials where systematic randomized clinical trials took place. These were tumors that have been curable for the last 30 or 40 years. I have to take my hat off to the pediatricians. They have a different set of patients, even though they're called cancers, they do behave differently in young people. And what anybody here in practicing oncology appreciates is that a Ewing sarcoma in a 2-year-old is a lot different than it is in a 15-year-old, and it's certainly different than it is in a 25-year-old. But we do use those guidelines that have come out of pediatric oncology. But these are the tumors that are fairly straightforward, and I should put non-Hodgkin's lymphoma in here too, instead of just Hodgkin disease. But this is where I think we had some of the greatest accomplishments in terms of sheer numbers, and that was looking at these intermediate stages, patients with lymph node spread of their disease or intra-abdominal spread in the case of ovarian cancer, and certain subtypes of patients with cancer, and ever increasing disease with HPV implications. Anal cancers are now highly curable with non-surgical approaches. Nasopharyngeal cancer is the same way. The majority of those patients should be curable with combination chemotherapy. Well, we still have some challenges, obviously. There are a lot of challenges. Not all of those patients in this list necessarily get cured, but a greater percentage, in fact, do, and we'll come back to that in just a second, too. If you look at where we still have challenges in terms of correcting the changes, biological changes that have taken place to create the cancer to begin with, you see the tumors listed here: stage 4 advanced breast and colorectal cancer. So the common cancers, stage 4 lung cancer, should be listed here too. And even though you have tumors that it would be debated as whether or not you ever cure them, the median survival of patients with multiple myeloma, for instance, is extended now out toward 5 years with different therapeutic inroads. But if you take a case like colon cancer and look at what the implications on survival would be, depending on whether it's localized in this instance, whether there are lymph nodes involved, as in this instance, or whether you have metastatic disease, you can decrease the mortality rate. And this has been around from even Dr. McKittrick's time. 30% decrease in mortality with the use of chemotherapy for patients who have node-positive disease at the time of their colon resection. But these patients are actually doing a little better. And I have to admit, if you were to ask me where in the world you get this, I got it a year ago and I can't remember now, so I can't cite it, so I probably shouldn't be using it. But if you look at what's happened in advanced metastatic colon cancer, you can see that patients their median survivals have improved considerably. That's due to a lot of things. It's not just due to the chemotherapeutic improvements, which there have been in the way of new drugs that are available and active in this disease, but there's a more aggressive take on patients with metastasis as well. Some patients with liver metastasis can be approached by surgical removal, or they can even have ablation. And the radiology department here is very good with invasive techniques at squelching these tumors even in the liver. So I think there is some real change if you look at 5 months versus 22 months. Even for patients with metastatic colon cancer, this has to represent an improvement. Then there are interesting little things that have come up in the biology of these diseases. Although brain cancers are rare, relatively rare, there is a subclassification, a histologic known as oligodendroglioma. And I'm looking back in a study that was done comparing radiation to radiation plus chemotherapy, you can see what the co-deletion of these represents in terms of survival with the combination. So finding this particular molecular arrangement in the patients with anaplastic oligodendroglioma really has implications for how they should be treated and managed. And this is not real shabby for a median survival of 15 years. Certainly not the common survival curve for patients with glioblastomas or more aggressive histologies. Well, in fairness, we do have some unfinished business, and we have had some downtimes, and we have colleagues in the area of epidemiology who largely feel neglected, and I can kind of understand that. If you were to look at what the inroads have been, I don't know, Fred, you can correct me, but probably one of the greatest advances medically in the 20th century was a clean water supply. And we can talk about what antibiotics and insulin did in the 20th century, but water supply was probably much more important to the survival of large numbers of people. And getting off of this kind of posture, where now it's verboten to light up a cigarette anywhere close to another human being, has made a difference. And I think when you start to see the decrease in mortality from cancers, it probably is due to this more than anything else. Not to neglect those of you who practice oncology out there. You've made some contributions. Well, epidemiologists have probably had a legitimate beef with the way funding of cancer research has taken place. Epidemiologist looks at the forest and studies what the trees are all about and looks at possible connections and correlations and necessarily causation. And the oncologist is sitting there looking at one tree very closely. And occasionally the oncologist can throw a number of these individual trees together and study them in a systematic fashion and give the results that I alluded to earlier. But in many steps of the way, you'll find books that have been published by epidemiologists lamenting what's happened in cancer research and cancer funding. And these we should respect that in particular review. And I would give you the book by Davis, which is more recent, about the secret history of the war on cancer, because it hasn't always been in taking advantage of the things that we might well have learned more from if we put a little bit more money into the epidemiology of the cancer. And if you read anything, you realize that our environment, and including our drinking water and our bottled water, probably are sitting around with lots of things that we run into the BPAs and baby bottles and a lot of things that aren't being done from an epidemiological basis that could be reducing our risk of exposure to carcinogens on our life. So, and then there was a very well-respected, Baylor is a statistician who has written over the last 20 years and looked at the data from the American Cancer Society, any other agency reporting on cancer data, and said, wait a minute, you guys, cancer isn't getting defeated. In fact, it looks worse. And that, he has two New England Journal publications about a decade apart rehearsing the same analysis. But by 2004, he's starting to change his tune a little bit. He's actually a co-author on an analysis from Japan, which suggests maybe there is actually a decrease in cancer-related mortality. Well, we aren't home yet. I got that in there more than I wanted. If you look at a book I would recommend particularly for oncologists is a book by Welsh, who's an internist who does a lot of epidemiologic data in the Dartmouth project. There's a lot of health information gathered at Dartmouth. And what he did in this book, is look at the possibility of overdiagnosis. And this is one of the treacheries we have in cancer medicine today, is diagnosing people earlier on, which we think does benefit some patients, but sometimes our early diagnosis may not benefit patients. And what he does is look at what the incidence, say, of melanoma has and how that increased over the last 35 to 40 years, and look at the mortality rate from it. It's flat. So whatever we're doing, we're making new diagnoses, hasn't really changed the outcome all that much. And the same can be said of thyroid cancers. We're really picking a lot of these up, I think, incidental to CT scans being done for something else. And everybody's getting their neck explored and their thyroid cancer removed, and then boom, what's really been the effect on mortality? It hasn't been there, I think.
Sir?
Yes, sir.
Are we looking at deaths per 100,000?
Yes, we are.
Thank you.
And again, I'd recommend this book, Overdiagnosed. I think it's really a kind of a balancing, come to a moment of realism. This is also in prostate cancer, and you'll notice the peak incidence corresponds to the enthusiasm for PSA testing. And probably all of these patients were largely overdiagnosed. One colleague who says, maybe if you get a family history of prostate cancer in a man who's middle-aged, you might want to do 1 or 2 PSAs. If they're normal, tell him to forget about it. But family history may turn out to be more important. There was actually a little increase in mortality per 100,000 around that time, and I don't speculate on that, but there were more invasive procedures being done also at the time. So there is a cautionary issue here. The real false start we had was when our enthusiasm for an approach to treatment outweighs our scientific knowledge of the subject. And this is a textbook, not textbook, it's a book analyzing the use of bone marrow transplantation in breast cancer patients in the 80s and 90s particularly. And what happened was that a very respectable investigator did phase 2 pilots with autologous bone marrow transplant in patients with metastatic breast cancer and in patients whose prognosis is just about as bad as 10 or more positive nodes. And he found each of these patient populations, small numbers, single institution, non-randomized, phase 2 stuff, that they had seemingly a plateau survival. So everybody got caught up in this. This went commercial. There was, I've forgotten the name of the company. There's a company that started doing these. And of course, the pressure was placed on all third-party carriers. As one of my colleagues who's not here today said, this is $150,000 stomatitis. And the mortality rates early on were between 5 and 10%. And of course, it was hard to get randomized clinical trials going when everybody wanted this treatment. And we went through a period of about 10 years where a lot of people were probably treated unnecessarily. It turns out that one of the pivotal, and I remember hearing Bezwoda, the South African investigator in Omaha in 1996, after his 1995 publication in a small number of patients extolling the virtues of bone marrow transplant. And it would look like the coup de grace. And the Omaha, the University of Nebraska folks were, wow, this is hot stuff. This is really the greatest thing. Then the NCI said, you know, these results look kind of too good to be true. We're going to have to review your data. So I sent a team down to South Africa, and in fact, patients were made up. The records were not available. They weren't kept closely. So the whole thing was blown out of the water. He's disappeared. I don't know where he maybe have cement around his ankles somewhere. I don't know. But anyway, after a decade of agony, finally the randomized clinical trials came out, suggesting that going through this arduous treatment did not benefit women with metastatic breast cancer. So it took us a lot of false starts, and in this book is appropriately titled False Hope. Well, that's been kind of the downtime. Now we've got some upswings here in recent times as well. Looking at targeted therapies and genetic profiling of malignant cells. Cancer profiling has been going on for at least 15 years, particularly with the introduction of Herceptin, but importantly, being able to type tumors in women as to their genetic risk factors for disease recurrence, new disease in the other breast, ovarian cancer. This has been a major contribution. There is another form of genetic analysis of tumors called oncotyping, which helps to divide the number of genetic abnormalities in a given patient, a specific patient's genetic profile of their tumor, and using that information as a code or a helpmate in deciding how aggressive treatment should be. So those have arrived. I've used it in breast. I haven't used it in colon yet. I don't know if anybody else has or not. You have. John back there's nodding his head. All right, well, I did borrow one quote from this book. I should mention it. This is The Emperor of All Maladies. I did mention it at the outset, but I did try to stay away from using it other than as to substantiate the dates, but I did borrow this one. The non-toxic curative compound remains undiscovered but not undreamt. Well, I think in fact some of that has happened. We had back in 40 years ago as a resident here, we gave L-asparaginase to a patient with acute lymphocytic leukemia, an 18-year-old, and he got an anaphylactic reaction. Didn't get a pancreatitis, but that was my first exposure to a targeted therapy. And as many of you are aware, the asparaginase is an enzyme that destroys asparagine, and in fact, children with acute lymphocytic leukemia are dependent, their tumors are dependent on an exogenous source. So if you destroy that exogenous source, you can get good remissions with this compound alone. In fact, that's what happens. The problem is resistance develops fairly early, and so within a couple of 3 months you have recurrence of the disease. The compound is still used, but it is in a sense just much like methotrexate against the placental cancers, a specifically targeted therapy, because there's an extraordinarily unique and important rationale for using it. And then all along comes all these oncogenes, tumor suppressants, and a very important one that has implications, the BCR-ABL1, or ABL, excuse me. And then there's kinase after kinase that have been produced and marketed. The first really specifically targeted growth factor in breast cancer came about with the recognition that some patients with this marker didn't do as well. So it was prognostically by itself not a good sign. But then an antibody was developed against it, which has been very successful. So the actual inroads in the treatment of HER2/neu positive breast cancer has been substantially improved as a result of this specifically targeted therapy. We also have been fortunate to have an anti-CD20, an expression of lymphocytes, an antigen on the surface of the lymphocytes that in fact are knocked out by Rituxan and bound by Rituxan, an antibody. And in fact, this compound has become the backbone of treatment for large cell lymphomas, improved survival rates and cure rates using this in non-Hodgkin lymphoma with chemotherapy. And from some patients who have this non-curable, low-grade recurring lymphoma over 15 to 20 years, this compound by itself without chemotherapy can be used. Well, the real home run hitter was this chap from Oregon. He was actually moved to Oregon so he could get some help from the Oregon lawyers he couldn't get when he was in Washington, D.C., and set up a connection with a pharmaceutical company in Europe to develop what has become known as Gleevec or amitinib, another great specific compound that targets what is fortunately a disease with very little molecular abnormality. The triggering mechanism for chronic myelogenous leukemia is uniquely one molecule, and you don't get that anywhere else. And so this was the home run. And the home run, of course, is, but this is what the fellows, there are a couple of fellows here that can tell us about. This is what you now do instead of the Krebs cycle when you start to memorize the influence of various antigenic stimuli and hormones. So this will give you some sense of what drives tumors and what prevents tumors from developing apoptotic death. So if you get this memorized, you can probably pass your boards easily. Well, there's been a plethora. I show this slide not because I want you to read it, but to show you that the FDA has approved innumerable numbers of tyrosine kinase inhibitors and antibodies that have very marginal impact on cancer patients. And I'm reminded of that. I think our atmosphere is now polluted by a large number of very low yield stuff. There is another issue here, and the elephant in the room is cost. The cost of some of the newly released FDA approved materials are reaching $100,000. I have one patient who was treated, fortunately, on a protocol before the thing was FDA approved. The cost of her melanoma treatment was, in 3 cycles, was $400,000 for 3 cycles, $150,000 a cycle for one injection of a substance that would knock out her immune system and allow the tumor to be taken care of instead of being interfered. Anyway, the cost is the elephant in the room, and it's not just oncology, but we do have a number of issues in oncology that we better straighten out on our own. And that's when we're getting $100,000 a year to improve survival on average of 2 to 4 months. Clearly inadequate, and unfortunately, the entire pharmaceutical world is driven by these extraordinarily expensive low yield. Well, I haven't finished with the bomb, if you pardon the pun. The real boondoggle in recent times is the proton beam. Theoretically, and radiation oncologists are to be commended for their evolution and their treatment from the day when I used to see patients who came in from outside hospitals who'd had chest wall irradiation with an x-ray machine that was in the afternoon used to take chest x-rays. So they got bombarded with gamma radiation. You wouldn't believe the number of problems we saw in the skin and subcutaneous tissues. That no longer really is a problem, so it's not something you see today. And I have to compliment the radiation therapy community because I'm about to be critical of them, so I don't want them to take they have evolved by concentrating their efforts both in terms of conformal CD planning as well as IMRT, or intensity modulated radiotherapy. And the whole goal has been to sustain the kill, a tumor kill that they need, with a minimization of normal tissue injury around it. And of course, protons are thought to be even more specific and targetable. You can get one of these for your backyard at between $100 and $180 million. You can have your own mini cyclotron. You can create protons, and you can charge almost $50,000, twice what the going rate for prostate cancer treatment is anywhere else with radiation therapy. Well, I don't know the answer to the cost. I thought this cartoon pretty much summarized where we are in our understanding of the economic issues. And if you look, I saw a recent non-cartoon. Medicare Defense, Social Security constitutes 78% of the budget in 2010, so the rest is just what's left over. But of course, we all have our own view of what constitutes waste. It's anything that doesn't influence us directly. And by God, keep your hands off my Medicare. Well, we covered a number of issues today, and I hope haven't put you to sleep. I don't see anybody nodding off out there. I'll never forget Gary Wood years ago, a pathologist. I was giving a talk, and it was right after lunch, and I was sure he was going to get a whiplash injury. Anyway, we've talked about the background, the scientific activities in the space community and how that carried over attitudinally into the treatment of cancer. We've talked about the ACT, talked about what we've accomplished, and I do think that we really have to look at this as a major achievement in what we've done as medical oncology. And then, of course, if I were a fellow out there, I can see one or two fellows here, I would say this is the best field you could have possibly chosen. I know Jared would probably disagree with me, but Jared, I think, was disappointed. I would go toward hematology at the beginning, but I think this gives you an ideal field, as does nephrology, really to combine your humanitarianism with people who are under a great deal of stress and have a great deal to contend with, both at the personal, economic, and social ends. Plus, it gives you now an ever-growing science, particularly with the molecular identification of patients' tumors, to really say, this is what I would do if I were starting over again. So thank you very much.